Good morning and good afternoon to all of you who have joined us today. My name is Eleftheria and I'm the Medical Science and Clinical Education Lead from Cardinal Health, and I'd like to welcome all of you today that are joining us for the webinar in honor of World Thrombosis Day. As we all know, 1 in 4 people worldwide are dying from conditions caused or related to thrombosis. 900,000 people in the United States alone are affected by blood clots every year, and about 100,000 of those will unfortunately die, which is greater than the total number of people who lose their lives each year to AIDS, breast cancer, and motor vehicle-related crashes. Cardinal Health is vouched to raise awareness and help educate around the risks of developing VTE. And today, we're very proud to welcome Dr. Javad Parvizi for this live webinar. He has graduated from the Sheffield Medical School in the United Kingdom, and he's a fellow of the Royal College of Surgeons of England. He is a practicing orthopedic surgeon specializing in management of patients and prosthetic joint infections and the treatment of this complex process. He is interested in pathways and standardized methods that can reduce post-operative complications such as VTE. Dr. Parvizi has also been part, and we are honored that he has been, of a global meeting of experts in an effort to identify and communicate an international consensus on appropriate VTE prophylaxis within the orthopedics field. Before we start this webinar, I'd like to kindly ask everyone to use the Q&A option at the bottom of your screens to submit all of your questions throughout this live event. I'd like to assure you that any unanswered questions will be answered via email in the case we run out of time. At the end of the webinar, may I kindly ask everyone to also take part of the survey, which will pop up on your screens after closing. And without any further delay, I would like wholeheartedly to welcome Dr. Parvizi and pass this on so we can start today's webinar.
Thank you very much, Eleftheria, and thank you to Cardinal for organizing this very, very important webinar. And thank you to all of you to be on this live webinar. And I hope what I am about to talk on is going to be of some use to you and your patients. So my name is Javad Parvizi. I'm a professor of orthopedic surgery. And as you heard from Eleftheria, I'm a practicing orthopedic surgeon doing roughly about 500, 600 cases a year here at Rothman Institute in Philadelphia, and I'm a professor of orthopedic surgery at Thomas Jefferson University. I am conflicted in that I am a paid consultant to Cardinal Health, but the talk that you will see today hopefully will concentrate on science and evidence and what the challenges are and not be at all biased about what we will be talking about. So Cardinal Health was very kind to provide an educational grant that has led to the generation of what we call the ICM VTE guidelines. And as you heard, this will be global guidelines that I'm actually going to talk to you a little bit about this as well. So the issue of venous thromboembolism, particularly in orthopedics, is a major one. Unfortunately, patients do develop this complication, and sometimes this complication can be fatal. So it's absolutely critical that us in the medical community pay attention to this issue, because this issue is definitely getting an attention in the legal arena, where at least in the United States, many doctors are subject to lawsuits because of their patients developing VTE, and sometimes non-fatal VTE as well. Currently, we have a whole host of modalities that are available to us in trying to minimize the risk of VTE. I don't think we can ever make VTE a non-event. It's going to occur, but our goal is to try to reduce that as much as possible. There are some challenges. One of the challenges is that there really has not been much change in the incidence of symptomatic pulmonary embolus over the past 10 to 15 years, despite the administration of aggressive modalities, namely drugs. If you look at this particular study in 2017 by Dr. Lieberman from USC, They looked at all the studies published between 1995 to 2016. They did a meta-regression to study the effect of time, and 18 studies were included on 27,000 patients, and they found that there was no change in the rate of VTE despite the use of potent anticoagulations. So this is sort of a little disheartening. Another disheartening statistics comes from the Australian registry, where you look to see if there is any difference in the incidence of fatal pulmonary embolus in patients who received no VTE prophylaxis versus those that received mechanical prophylaxis and those that received chemical prophylaxis. Interestingly, the incidence of VTE was low, fatal pulmonary embolus, was lowest in patients that received mechanical only VTE prophylaxis. This is very interesting. The administration of aggressive anticoagulation, at least in the Australian patient population undergoing orthopedic procedures, namely hip replacement here, did not make a difference to the incidence of fatal pulmonary embolus. Another study by Dr. Sharrock and Dr. Salvati from Hospital for Special Surgery, they looked at studies published between 1998 to 2007 that included all case studies related to mortality and pulmonary embolus. 28,000 patients were included, and their finding was that mortality was actually higher in patients who received potent anticoagulation versus those that received nothing or mechanical prophylaxis. Administration of chemical prophylaxis does carry some significant risks also. It can cause hematoma formation, can cause extensive ecchymosis, blood loss, drainage, and it can actually lead to an increase in the incidence of periprosthetic infection. If you look at some of these articles I'm quoting here, including an article from our institution, showed that administration of aggressive anticoagulation, namely in the form of chemical prophylaxis, could lead to some of these complications, which are not insignificant. Because of that, there has been a shift in the United States away from chemical prophylaxis towards mechanical prophylaxis and aspirin. This is a survey of over 3,000 attendees of American Association of Hip and Knee Surgeons. This is a live survey that happens during the annual meeting that takes place in Dallas. You can see that there has been a definite shift away from the use of low molecular weight heparin, Coumadin, and other injectable anticoagulants towards the use of aspirin plus mechanical prophylaxis. In the latest survey, 93% of surgeons in the United States would be using aspirin and mechanical prophylaxis following total hip and total knee arthroplasty. And that, I believe, is a wave of change that has started, that's affecting the other countries around the world also. Talking about around the world, the mission of the International Consensus Meeting was to bring experts around the world to determine the state of art related to venous thromboembolism in patients undergoing orthopedic procedures. And by orthopedic procedures, we mean every orthopedic procedure, not just total hip, total knee. And this was with the intention of trying to improve the care of patients by minimizing the risk of VTE after orthopedic procedures. You might say, why bother? Well, the first is that unfortunately, literature is not definitive on many of these issues. And I've highlighted some of those already. And much of the science we know is really very limited. And unfortunately, to generate that high level science doing randomized prospective studies, sometimes we need patients in the tens of thousands to be able to answer one question related to VTE. In fact, Dr. Pellegrini started and should be congratulated for starting this PEPPER trial. And as you will see, this PEPPER trial has been ongoing for many years, since December of 2016, still not completed. And the number of anticipated participants is around 20,000. So these are very, very challenging studies to do. And there are obviously limited resources for the conduct of these level 1 clinical trials. The other thing that I can tell you is that not always we need randomized prospective studies. Look at medicine. There is many things we do in medicine that's not based on randomized prospective studies, and nor will any of us want to ever do this on a randomized prospective basis. We wear gloves during surgery. We wash our hands before we go into the operating room. The discovery of antibiotics, the administration of anesthesia, all of these are based on observations and not randomized prospective studies. The science of Equipoise, or the ethical aspect of Equipoise, is also very important. This basically talks about when you believe in something being right for your patients, to randomize them to an arm that is not the same treatment could represent ethical challenges. If I believe giving aspirin and mechanical prophylaxis is the right thing to do for my patients, randomizing them to Coumadin could represent an issue. And that's why we actually did not offer to be part of the PEPPER trial. None of the surgeons in my institution agreed to do that because they felt that they were already convinced that giving aspirin and mechanical prophylaxis was the right thing to do for their patients. And the issue that surrounds us in orthopedics has led to generation of numerous guidelines, many of which you're familiar with. American Academy of Orthopedic Surgeons, obviously the chest guidelines that we're all very familiar with, NICE guidelines, Scottish guidelines, and many others. Majority of these guidelines are actually related to hip and knee replacement in orthopedics and doesn't include other fields of orthopedic like spine surgery, sports, etc. Right now, there's minimal guidelines on what to give a patient who undergoes ACL surgery or rotator cuff repair. These are very common, very common procedures, and we need to know what to do for these patients in an effort to try and improve their care and prevent this disastrous consequences, namely VTE. And some of these guidelines have only reviewed the chemical prophylaxis and not looking at the other alternatives. These guidelines are also contradictory. If you look at some of them, recommend one agent versus the other. The time or the period for coverage of these patients varies from one guideline to the other. And some of these guidelines, I will argue, are outdated because they are based on very old literature. Because of these challenges that lies ahead of us, we decided to bring a global group of experts that will review the literature based on the Delphi method to come up with the international consensus guidelines. We've had experience in doing these guidelines. We have 2 guidelines on infection, which the first one was in 2013 and the second one was in 2018, with over 900 experts from over 200 countries that came together. We reviewed everything that was available in the literature and came up with written guidelines that have become the roadmap for many of us in orthopedics related to infection. And this was a personal meeting at that time, but obviously the guidelines that we will be conducting right now is all going to be virtual. And if you look at the number of societies and the countries that were represented, were massive. Those guidelines were also conducted using the Delphi method. Many of you are familiar with this. It's a very strict process of reviewing the literature, pertinent literature, selecting the appropriate delegates. How do you decide on which delegates those should be serving? It goes through a consensus building, voting twice if necessary, and then coming up with the final product. The Delphi method has actually been around for a long time. It was used as a forecasting process for frameworks. It's been used by Rand Corporation, and it's the best way to reach agreement in subjects like the VTE, where there is either contradictory science or there's not enough science at all. So it aggregates the opinion of experts, and it does bring the experts' opinions into a scientific ground and provide those for us. So because of the pandemic, we have actually used a virtual process, and it's been done with the use of Zoom, occasional small personal meetings. We have selected the delegates based on two criteria. One, they had to have had publication in the subject of VTE in orthopedics, minimum 3, or they needed to be nominated by this society. And interestingly, society nominations were usually of delegates who are known experts in the field and have published papers in the subject. We then put together various areas of orthopedics, included trauma, oncology, upper extremity, hand, hip, and knee. And then we brought these delegates together and then invited them. There may have been some delegates that we unfortunately missed their publication records, and there may have been one or two that actually declined to participate in the overall consensus. We gathered 570 delegates with 115 countries represented, 135 societies have endorsed it, and the societies are not just orthopedics, hematology, anesthesia, cardiology, and numerous other specialties that have an interest in minimizing VTE following orthopedic procedures. The collection of questions started in March of 2021. We reached out to delegates and said, give us the questions that you feel need to be addressed in the field of VTE. And we would get questions like, should you be giving any anticoagulation to patients who are undergoing ACL reconstruction? Or it could be, what is the optimal length of VTE prophylaxis? Are there differences between different types of mechanical VTE prophylaxis? Is there a difference between gender and race and age in patients undergoing orthopedic procedures? Can you give VTE prophylaxis to patients who are undergoing spine procedures? Should the VTE prophylaxis for patients who've had a prior DVT be different than those who have not had it, etc.? When should you stop the oral contraceptive medications prior to orthopedic procedures? So you can see that the list was massive. And there were quite a lot of questions received. We asked each delegate to give us 5 to 10 questions. 670 questions were received. And then we started to get together and started to rank these questions based on the order of priority and the importance. And if one question was being asked by many delegates, we felt that that was an important question that needed to be included. And all of these questions were then discussed, the duplicates were removed, and we were down to 200 questions that have become the work of the international consensus. And you can see that the questions were then ranked in this Excel sheet. And then we had Delphi experts that helped us to rewrite these questions. And it's very important, how you ask the question is going to beg the answer. So if I told you, what is the role of aspirin in prevention of VTE following rotator cuff repair, is very different than if I asked you, is there a role for administration of aspirin following rotator cuff tear? So we can't ask in the Delphi procedure suggestive questions. They have to be open questions that then begs the delegates to go and evaluate the literature to find an answer for that particular question. So some of these had to be readjusted, rewritten to fall within the guidelines of Delphi. And you can see that the committal questions had to be removed. So once these were done, then we looked to see who amongst the delegates had published on that field related to the question. So if I asked you about the role of aspirin after ACL reconstruction, or whether we should give any administer any VTE prophylaxis, we would then develop the mesh terms to look for everything and anything published related to VTE prophylaxis following ACL reconstruction. And an author that had the most experience in that field would then be selected to answer that question using, again, the Delphi method, systemic development, etc. The actual mesh terms were actually developed by the Cochrane Group in United Kingdom, and the mesh terms were then shared with the delegates to make sure that the literature search was absolutely evidence-based as much as possible. And as you know, this pyramid of evidence was then administered to look for as many of these high-level studies as possible. And in the absence of evidence, then the delegates were responsible for developing a consensus, which would then undergo review by the experts, and then we would administer those through a vote. We also had the Thomas Jefferson University Library help us. We have librarians here that are extremely skilled in conducting systematic review, and they helped us immensely in developing the mesh terms and administering those, but most importantly, retrieving some of these articles that were difficult for the delegates to retrieve. And they would reach out to us, ask us about the number of publications that we needed to review. Over 200,000 publications were reviewed. Some of these are, of course, duplicates. And the mesh terms were developed in a very, very systematic fashion to make sure we did not miss any of the potential publications related to each subject. And when you actually ran this literature search, you would come up with numerous articles that then the delegates had to screen, remove those irrelevant articles, and then review the abstracts of the relevant articles and pull the full article on those that needed to be evaluated. Then the data would be extracted, and then they would be, the consensus or the recommendations would be developed. We were continuously in communication with the delegates. Majority of them are incredibly dedicated physicians and scientists who worked tirelessly to develop the document. Multiple emails were exchanged during this time. We had a very tight timeline, which we wanted to stick to, and the delegates came through incredibly well. We have had these documents on the website for interdelegate discussions. They're actually still on our website, called ICM Philly, International Consensus Meeting Philly. If you're interested, you can definitely reach to that website and also access those. These are open to people to look at. And we have then reviewed these documents by 2 other delegates. These were peer reviewed. Many questions arose during that process. Then they would go back to the delegates who wrote the article in the first place. Then each section, each subspecialty had a section editor who was an expert in the field who would read through every article and then edit those further. And this generated over 4,000 emails that goes back and forth still until we get the final documents, which would then go for voting. The documents will be merged together, and then we would send these out to the delegates to be reviewed again, and then to be voted on at the end. So this is where the document is currently on VTE. It's the ICM Philly website, and all the questions with the answers to them are there for you to see if you're at all interested. They've been there for the past 2 or 3 weeks, 2 or 3 months, excuse me. We have generated an app which will then become available later down the line. And one of the goals of this app, and thanks to Cardinal for sponsoring this particular educational activity again, is to develop an app that can risk stratify the patients. So no 2 patients are the same when they're undergoing orthopedic procedure, or for that matter, any other surgical procedure. What we would like to know is what the risk profile of a given patient is, and what would be the right VTE prophylaxis for that particular patient. The app will be hosted under the ICM Philly, where we have all the other relevant apps right now, and it will be available to anybody and everybody who wants to use it free of charge. And this will then be helping these delegates and the other medical community to be able to risk stratify their patients. So, you know, the total joint arthroplasty is changing immensely. And what we were doing 20 years ago may not be the same as what we're doing today. And this is an email I received from, you know, one of the delegates, in that it tells us that this has become the Wild West. We need to really bring some harmony and science and some process into this project. And as Eleftheria told you, the intention of the international consensus is to develop a process-based protocols that we can all use to try to minimize this devastating complication in our patients. So once the documents undergo final review, we will then be putting them in a publication method. There will be input that we will seek from the experts, and the published documents will definitely be voted on by the delegates. And then if there is disagreement, the document will have to go back for reevaluation, rewriting, and revoting. And this process has started currently, and we're in that final stretch with some of those. We're administering these through SurveyMonkey, and then the intention is that we will be publishing the entire document in Journal of Bone and Joint Surgery as a peer-reviewed document that can be citable, accessible, and hopefully this will help people in the future. The subspecialties that we have is actually on those listed on the slide. Every subspecialty in orthopedics is included. We have around 100 questions that are on the general category. You know, questions like, is there a role for the use of non-steroidal anti-inflammatories for prevention of VTE? Can non-steroidal anti-inflammatories and aspirin be co-administered? Can aspirin be co-administered with one of the injectable drugs? Are there differences between the injectable drugs for VTE prevention? And a lot of these general questions are those that we're facing currently in our practice. And I think this will bring some form of harmony and standardization. The documents will then be translated to numerous languages, just like what we did with the infection ICM-VTE document, numerous publications, and the translations are actually on that website, on the ICM Philly. Similar similar activity will take place with the ICM-VTE when the time comes, and we will have those posted. The entire document with the references, with the appendices, obviously all will be housed in that app, which will be accessible to the public also, not just the medical community. We will also be continuing to monitor the field of VTE in the years to come. And each week we will highlight a paper that we feel is contributing towards the science of VTE, much like what we've been doing with infection. And that app will send a notification to its users, and hopefully, the sharing of this knowledge and education will help us move towards a better way of caring for our patients. The VTE risk calculator will most likely become functional in the next 2 to 3 weeks and will be available to anybody to use. And I think this will be a very, very important step in the right direction, because not all patients have the same risk factor for VTE undergoing the same procedure. That's true for everything we do in medicine. We need to individualize the care of these patients. And not every patient is a candidate to receive aspirin. There are patients that may require something more aggressive, etc. We will be collecting an article bank related to VTE, which will be accessible to anybody who wants to access these faster, and they will be all there. And we will continue to disseminate the app with the help of our industry partners like Cardinal that are committed to prevention of VTE after surgery. And I think this will become very, very important for us in trying to care for our patients. So we will be having that app, and hopefully we will be able to share that with you down the line. So again, this is it was a gigantic task that took 570 delegates to complete. 200 questions are almost completely done. There has been massive representation globally. This is not just an American activity. This is everybody and anybody around the world who wanted to be part of it. The societies that have endorsed it are not just orthopedic societies. It includes cardiology, anesthesia, hematology, etc., as I said. And I think we will definitely have this available before the annual meeting of the American Academy of Orthopedic Surgeons, which is going to take place in March of 2020. thank you very much for listening to this. And I'm really grateful to you for your commitment to prevention of VTE. And this is the app. If you don't have it, please feel free to download it. And please feel free to review those questions, take a look at them. And if there are any questions at all related to these questions, share them with us. There's a commentary box on the app, but you also can directly write to me on my email, and I'll be glad to hear from you. Thank you again for everything you do in trying to prevent this terrible complication in our patients undergoing surgical procedures.
Thank you very much, Dr. Parvizi. I think I speak from everyone today saying how informative and wonderful it was for you to summarize everything you're doing on the background, just to make sure that we are standardizing the best care we can actually offer. So we do have some questions from our participants and delegates. However, I was wondering, before we start answering those questions, whether you could elaborate a little bit for us. What do you foresee the process would be after the consensus is finished and we know which changes we need to be looking at and how to standardize our care for our patients? How do you foresee, how long do you foresee those changes to take place, take place? And also, how do you see the wider community to accept those changes and actually implement them?
That's a fabulous question. Change in medicine comes very, very slowly, and we're all aware. One thing that can accelerate that change is the dissemination of the information and the material, and also ensuring that people who are using and looking at this document are aware that this was a process that was very, very scientifically grounded, without any potential bias or very minimal bias. And it is intended to help the patients, not to serve one company or another, not to serve one person or the other, one society versus the other. And that's why we've had 135 societies endorse this process. The societies are all intending to have these documents on their website. Their delegates to be talking about this document on the podium. If there are processes like American Academy of Orthopedic Surgeons has, to then introduce these into the orthopedic community with the intention of trying to standardize the process as much as possible. It won't be easy, but our experience from the infection world shows that it was incredible. Like the first international consensus meeting we held, one of the questions was, what is the definition of periprosthetic joint infection? There were so many definitions for periprosthetic joint infection because there's no absolute test for diagnosing infection. So that international consensus meeting came up with the diagnostic criteria. And interestingly, that was then adopted and is still being used by the CDC, for example. So we do think that the governmental agencies are watching this process. We do have contact with them. They all mean to do the right thing for the patients. We will definitely continue our dialogue with them. Hopefully they will find the document that's generated of value to endorse it and to try to also help in implementation of these documents moving forward.
Brilliant. Thank you very much. We do have a question from the audience actually referring to any conflicts of interest. So we all understand big initiatives like that. Yes, they do need help, from the patient to understand what has gone wrong, from yourselves, because you have all the expertise of how to deal with things when they go wrong, but also from companies, because we also want to understand how we can improve everything that happens around our patients. However, one of our participants is asking whether you think it will be a potential bias regarding conflict of interest of the delegates, and how is industry involved in this project and the conflict?
Yeah, that's a great question from Dr. Marin Pena. He is a fantastic friend of mine, wonderful and world-renowned orthopedic surgeon from Spain. He actually is part of this process, and he's done an amazing job of bringing us where we are. In fact, he was one of the first people who came up with this idea of having an international consensus meeting on VTE. So these activities are extremely labor intensive, extremely gigantic in their breadth. They do require some funding, and the funding is to cover the cost of literature search, pay for librarians, for the Cochrane, buy the softwares, to hire biostatisticians, et cetera, et cetera. So we did apply for an educational grant. And as I stated in the beginning, Cardinal was very kind to give us an educational grant for this activity only. That's the only industry funding we have had. We did not reach out to any other industries. We don't have any other industry involved in this process. We don't have any industry representatives in this process. I'm not actually against that idea, but we just don't for that perceived conflict of interest issue. So industry has had no role at all in development of these guidelines. And as I said, the grant that has come from Cardinal has only been to cover the cost of some of those things that were absolutely necessary for the conduct of the international consensus. So I'm pretty confident that the bias in this process has been very minimal. But I think his question is also could be seen in a different way. What about bias from delegates? Let's say I am a very strong advocate for aspirin and mechanical prophylaxis after hip replacement. And if you gave me the question, maybe I would write that question in such a manner that would overlook publications against aspirin and mechanical prophylaxis. And my document, even coming from a scientist and a physician, would be biased. Yeah, that definitely could be the issue. So that's why, first of all, each document was written by 2 delegates, not 1. Secondly, these documents were then reviewed by 2 additional delegates other than those who wrote it. Then the document would go back for feedback and changes by the initial delegates who wrote them. Then this would go back to the section editor of that particular subspecialty for additional review. And actually, I read every 200 question. I edited every single one of them myself. And we have a very active biostatistics and bioethics group here that continuously monitors publications. One of the documents that was written in September 3rd was very important document related to bridging with chronic anticoagulation. And there was a publication on September 4th on this exact subject in British Medical Journal. So we had to send that document back to those delegates to make sure that they included the reference to that September 4th article. So this was a fluid process. It wasn't like something we came up overnight and I sat there and I wrote what I think is right. This is coming from, again, a representative of 135 societies and delegates and scientists and incredible thinkers like Dr. Marin Pena himself.
Brilliant, thank you very much. I think that actually puts a lot of faith in all of the participants of this webinar that the utmost attention has been taken in order to avoid any bias. We do know that bias is around us and sometimes it is unconscious. And as you said, a lot of people are advocates of specific ways forward. And when they have always worked and they have always benefited their patients, they will vouch for these best practices. However, as you have explained, you have taken every possible route to avoid bias and make sure that everything is cross-checked and making sure that the best way forward will be decided in the end. We do have a question about the voting process, and do all the delegates vote, and what are they voting on specifically?
Yeah, great question. So delegates of each subspecialty are voting on their question. You know, if you ask me, what's the role of a low molecular weight heparin after shoulder arthroplasty, I would not be the right person to be voting on that because I have absolutely no idea. There's no point in sending that question to me because I would be abstaining. And because of that, we're sending the subspecialty questions to the subspecialists that are either experts and surgeons in that particular field or they have published in that particular field. We are copying our steering committee. Oh, I forgot to tell you, we have a steering committee that overlooked this whole process. So we would reach out to them. They would have to weigh in on this process also. So they are seeing the questions. Some of them may feel qualified to answer them. Some of them may not. The general questions, though, will go to all the 550 delegates, because that actually is very important for everybody. Like, there are two questions here that are very, very good questions. One of the attendees is asking, how does giving TXA during a procedure affect post-operative VTE? Absolutely brilliant question. Very, very important one. A question that's continuously coming up on a daily basis between the surgeon, the anesthesiologist, etc. That question has been answered. And that is one of the general questions, because that applies to every orthopedic surgeon and not just the shoulder and elbow. So that will go to everybody in the general group for voting. And to answer that question, by the way, it's not to keep you suspended. VTE risk incidence is not affected by tranexamic acid, administration of tranexamic acid at all, because the mechanism of action of TXA is very different. So the recommendation is that TXA should be administered to patients with prior history of DVT and venous thromboembolism. The only contraindication to administration of TXA currently, based on TXA guidelines, is people who have allergy to TXA. That's it, no more. The other question they ask is very important one. It's like, how did you come up with the risk stratification tool? Actually, Dr. Caprini himself was part of this ICF VTE. He was one of the delegates who answered that question. What risk stratifications are there to determine the risk of a patient undergoing orthopedic surgery for VTE? But as you can imagine, and I absolutely admire Dr. Caprini, and I'm not intending to imply this is the case, but you could potentially think that Dr. Caprini, writing that question, would potentially endorse his scoring system and overlook others, introducing the bias that Dr. Marion Pena was talking about. That's why Dr. Caprini was matched with another delegates, actually two others, and that's why that document would then have to undergo scrutiny and review by multiple other people before that became the standard protocol or the procedure here. So the voting system, to answer it in a very long-winded way, subspecialty questions go to subspecialists and the steering committee. General questions will go to everybody. And we're saving the general questions to last. They're completed, but they will be going last for the vote.
Just one question that rose to mind while you were talking about, delegating the questions according to speciality and also general questions. Do you also separate some of the questions that you have depending on what type of patient you're addressing, whether the patient is a low risk or high risk patient? Do you also have this sort of branching on your process?
We do. Yes, absolutely. Great question, Eleftheria. So on the rotator cuff tear, by the way, for example, since we were talking about it, the shoulder and elbow have made a recommendation that there is no role for administration of routine chemical prophylaxis to patients undergoing rotative cuff repair, except in the high-risk group. And then they define who that high-risk group is. So your point is a very valid one, and it really goes back to what I said earlier. We have to individualize these protocols. You can't write a protocol that applies the same to somebody who's had 16 prior pulmonary emboli versus a 35-year-old super athlete undergoing the same procedures. So they are not the same patients. And we have to make a distinction between high risk, low risk, maybe even medium risk. And that will be taken into account every time a question is being answered.
Brilliant. So I was wondering, going back to the risk stratification tool, whether in the beginning we will still be able to compare and contrast it to the Caprini score, just to make it more familiar to people. So if the new risk would be different, would we have a reference of what it would have been if it was under the Caprini score scale?
Yeah, so the new risk stratification is not the Caprini score. It is including some of Dr. Caprini's wisdom and he's contributed immensely to the development of that particular risk stratification. It doesn't have a name. It's going to be International Consensus Risk Stratification, and it's actually being validated right now as we speak. We have sent it to 4 international centers. It actually includes, I believe, Dr. Marine Pena's group, 4 international centers and 16 American centers to validate it. So we developed the process, we developed the risk stratification scores. Now it's in the external validation step. And if it gets validated, which I hope will be, and I feel it will be, then that will be made available through that app.
Okay. Do you know how long the validation process is taking?
I think we have just started that process, and we are hoping that all of this will be done before the end of the year, because we have that timeline of introducing the guidelines either at the American Academy or beforehand.
So we can consider it as a little Christmas present for all of us.
That would be amazing. That would, yeah. I think these delegates definitely deserve to see this. They have put so much time and energy into this. It is beyond description. I cannot tell you how much and how many hundreds, if not thousands, of hours each delegate has put into this process. It's been amazing.
We do have one question anonymously from a representative of mobile SCDs. What would you say to an orthopedic surgeon who may not be informed of SCD benefits and they use medicine only?
Yeah, you know, I think this is one of the important problems that we're facing today. There are numerous modalities for prevention of VTE. A majority of the guidelines have concentrated and focused purely on chemical prophylaxis. And as I showed you on the Australian registry, you know, there's a signal that mechanical prophylaxis not only work, they seem to work a little better because they reduce that all-time fatality that Dr. Sharrock and Dr. Lieberman have pointed out in their studies. So is there a role for SCDs? Absolutely. Absolutely a role for SCDs. There is plenty of evidence to show it, and the document is going to reflect it with numerous level 1 studies that are done. So this is the task of the International Consensus Group, to really educate those who are not aware of the publications and the role of SCDs in prevention of VTE. I am personally very, very much in favor of SCDs over anything else, because they are not only important in prevention of VTE, they have other types of benefits, reducing edema in the extremity, the patient satisfaction, etc. All of these things. And of course, they're associated with no risk at all in terms of bleeding, systemic side effects, etc. So we just have to educate. We just have to educate the surgeons and the physicians and the group that don't know about the role of SCD, and show them the documents and show them the numerous publications, including level 1 studies, in the hope that they will embrace the SCDs, at least for a group of their patients. Maybe SCDs is not for every one of their patients undergoing the procedure, but definitely there is a role for SCDs.
I think we do have a long road ahead of us, don't you, of education. I mean, the biggest part is actually everyone agreeing and understanding of what the best way is forward. So how should we treat specific patients depending on the risk, depending on the procedure that they're having, previous history and everything. But of course, I think the road of education ahead of us when everything's actually ready will be even longer. It won't be as difficult as the road that you are leading right now, because I know communicating with so many delegates, making sure that nothing is biased and making sure that we will come to a common end for a better and improved patient care. It is a very, very difficult task, but I do foresee that education will be taking a long road ahead, and a lot of effort from everyone's part, including the patients, because I think even educating, I don't know what you think, but you know, even educating the patient moving forward of why it is important to take the road that we decided to take for their treatment is an important task.
I completely agree. And I really think that's what we are all here to do, to educate our colleagues, educate ourselves with the intention of improving patient care. If one thing is better for our patients, we definitely need to implement that over the others. And I think time will show that this gigantic activity that we all got involved in is going to serve our patients in the long run. And again, I can't thank Cardinal enough for providing that educational grant that made it possible. I can't thank the 550 delegates who have been unbelievably devoted to this process. And it's in your introduction, Eleftheria, as you said, this is an important problem that we face. This is an important problem we're losing our patients to, and we owe it to our patients to do everything and anything possible to try to minimize this problem in the years to come. And I honestly think that's why there was so much engagement, so much energy, so much dedication from these delegates to make sure that this process goes smoothly, goes expeditiously, and the document that will be generated will become, in my opinion, the Bible of VTE prevention after orthopedic procedures.
I really, really like how you described it. And thank you for using those words. Yes, I think it will be close to the heart of everyone that will be assessing and also treating a patient coming forward after this whole work is finished. And one of our attendees is actually, asking us what are the major outputs that we hope to achieve when everything is published. I don't know about yourself, but I really want to hope, and I do believe that the most major outcome is to see a dramatic reduction in the occurrence of VTE that can actually be prevented if we understand it a bit better and we have better risk assessments and treatments. What do you think?
Absolutely, absolutely. So Australian Orthopedic Association, multiple Australian organizations are part of this process. And as soon as the process is there, they're going to definitely implement this nationwide. That's been their intention. So that Australian registry graph that I showed you is probably going to reflect when this was implemented, and we will see if that made any difference to the occurrence of VTE and in VTE-related deaths. Institutions will pursue these. I think there are governmental agencies that will be involved. Absolutely, very important to measure that what we are doing is making a difference and we are not harming the patients by doing something that may not be right. But we will be pursuing these, like what we have done with the infection. There have been outputs that we measured. This one is a little easier than the infection one, but we will definitely be looking for outputs because they are very, very important. I agree.
And I think it's a very timely project as well, because earlier this year in 2021, we were faced with a new publication in the Anesthesia Journal stating the higher risk that patients that have even recovered from COVID have been facing with VTE occurrence, even when they have recovered 60 days after the COVID infection, when they're going in for their elective surgery. So do you think, in your opinion, that this will be taken up by a lot of our VTE teams as well, and infection prevention teams who are dealing with the side effects of COVID, and also the effect, if you combine COVID and elective surgery?
Yeah, absolutely. In fact, those are questions in this document, by the way, and they're actually live on the website. You can take a look at them. Even vaccination has also been discussed with the COVID. Absolutely. I mean, these documents have got to be timely. And yes, it is seen that the patients with prior COVID carry a slightly higher risk of VTE compared to those who don't. And we are actually now in a multi-institutional data analysis step to try to answer that question, trying to pull data of patients who underwent orthopedic procedures, hip and knees, who had COVID versus those who didn't. And by having COVID, I mean recovered from COVID, not active COVID. Obviously, you wouldn't do an elective arthroplasty in an active patient. So that data will also help us in formulating that document. Yeah, these are great questions and very important ones. Science is a fluid thing. What I say today may not be true tomorrow because there will be further evidence emerging. And that's part of the reason why we have this app, we have this website, we have this potential interactive platform, we need to continuously look into this situation and try to make them make the best standard procedures as much as possible.
Brilliant, thank you. And you know, once again, as a former scientist myself, but also now as a medical science lead and clinical educator, I'd like to thank you from all of us for entering in this, you know, gigantic task. And we do have very positive comments in our Q&A box as well, commenting of what extremely interesting presentation you've just delivered and the important task you have undertaken. But we do need to always concentrate on the fact that we are doing it for the patient. We do put the patient first, and we do want the best outcome, so we can have, as you stated in the beginning of your presentation as well, less and less VTE occurrences. That will be the optimal goal. It is preventable, and we should prevent it. We just need to be more vigilant and understand it better and make better assessments in front of our patients. So I think coming up to time, to the hour, from myself, and I'm sure from all the participants of this webinar, we would like to wholeheartedly thank you for everything you have done and for today's presentation. It has been extremely informative, very, very well delivered for all of us. And I think we leave this session much better educated. And thanks to you and your team of all these delegates that are undertaking this task.
Yeah.
So I'd like to
thank you enough.
Thank you. But I'd like to remind everyone that when this session will close in a couple of minutes, there will be a post-webinar survey, and we would kindly appreciate if everyone took a moment or two to answer their questions. But for the time being, and in honor of World Thrombosis Day, I'd like to thank everyone and Dr. Parvizi for their participation and their questions. Have a good day and a good afternoon from wherever you've joined us today.
Thank you, everyone. Bye-bye.
Goodbye.